what are the problems with this case. Okay, so have a look at it, close look. What happened to him? He had a POP cast applied. Annotate, undo, participants. Okay. And plan to have a conservative management. So he has been told that's okay. This is a simple injury. It's not annotate, fin annotate. He was told that this is a simple injury and you do not need to have anything done. Okay. So, what do you think? Other options? Remote control.
You ask the panel, Dr. Kholeif, or you ask the audience to write in the chat, or we just ask?
Asking the panel because yes.
Well, if you can go back just one slide to see again this X-ray, I just making a double screening here on it, and I can see a small fissure fracture here in the fibula, but there is something wrong in this area. I think in the anterolateral corner. Maybe something wrong in Deltoid chapeau or something wrong in the talus. So if you ask me, I would ask for a CT scan to see more details about this fracture.
So this is it creates a very high index of suspicion, and as you can see, this is not a true AP view. So there might be some talar shift here as well. So definitely, a CT scan, we should be having a high index of suspicion, high velocity injury. Such a young man was sustaining this injury, so we need to have something done. So this is his CT scan, as you can see. So we can decide what are the components of the injury. You can see from here first, there is a fibular fracture.
أنا أكل أي حاجة.
عايزين نعمل allow participant يبقى عندنا أول component syndesmotic injury. I think, what do you think about the syndesmosis here?
Yeah, it looks now it looks separated, and there is syndesmotic injury, definitely, yes. And I think also the medial clear space is a little bit wide here.
Medial clear space is a wide as well, and we can see.
And we have also fracture here is most anterior part, so maybe distal tibial fracture or talus.
Exactly. Exactly. So it is not as simple as we thought before. There is something in. So there is a lateral injury and there is a medial injury. There is a syndesmotic injury. There is a talar injury as well. The axial cuts, as you can see, this is the plafond. You can see this amount of comminution. You can see the fibula has moved a bit anteriorly with the syndesmosis open. So definitely there is a syndesmotic injury in here with this severe comminution in the CT. I usually like to have this 3D CT scan. So if you can look at here, definitely the fibula has moved laterally. There is a good fragment here, but there is some comminuted fragments here. So I think we know that we are going to end up with having some arthritic change because you cannot have this, you cannot restore this as original part. And you can see here the medial clear space, definitely there is lateral talar shift. So these are the components of the injury. So what are the recommendations? The panel?
Of course, for me, I think we need to make open reduction internal fixation I would suggest fixation of fibula and also putting a syndesmotic screw or something like that. The deltoid chapeau needs to be fixed. I may need some bone graft here for this comminution to make impaction here, and I may fix it with a screw and washer, large washer. And finally, I have to assess after the end of the day, I have to assess here the medial clear space. If still there is medial instability, I will do a medial ligament repair. And I think you said there is a fracture in the talus, yeah, right? So it needs to be fixed as well, I think. Yeah. This one. So this cap needs to be fixed with headless screw or a rigid pin or something like that.
Any other recommendations?
I think the addition of an ankle arthroscopy during the fixation would be very valuable. If you go back to the CT, you will find there's a part of the fragment in the syndesmosis. The axial cuts, please.
Yes.
Yes, there. You see there's a part of the fragment in the syndesmosis, which otherwise would not be seen. This is the part of the AITFL, the anterior inferior talofibular ligament. So the reduction with the comminution might, if you do it open, although it might be a good option, but you would not be able to reassess exactly how much, because of this comminution, you will get the tension back to the AITFL. So you might depend on the syndesmotic fixation itself. For example, if you use a screw or whatever type of fixation, a suture button to fix the syndesmosis. But if we have the loose body in the syndesmosis and we do not restore the tension of the AITFL, this part would still remain abutted anteriorly and we would have lost a part of the syndesmosis. I don't know, this is just my opinion about this. The other value for the arthroscopy is at the same time, you might look medially. And then if you see the deltoid is overturned into the medial talar gutter, then you might decide to start medially, remove the debris, release the gutter, and then go back to allow the talus to fall back to where it should.
Would you do the arthroscopy after finishing your reduction, or after putting your plates and screws and doing the syndesmotic screw, or before that, or what?
In these cases, I would like, as we will see later on in some other cases, I would start off with the arthroscopy as using as an assessment tool and know where to start medially or laterally, know if I have intra-articular debris. Especially here, you have an osteochondral fragment, which you might be able to fix even percutaneously, and it would reduce the degree of the open procedure. You might be able to do that with a clamp percutaneously and then fix a Herbert or a headless screw. And I would keep the scope, use the fluoroscopy views to assess reduction by the two plane, but I would use the scope post-operative or after the fixation to assess my degree of reduction.
I think this is a very useful tool. I totally agree with you, Professor Nasef. So which approach would you like to use here?
Which what?
Which
approach?
Yeah.
Okay.
Yeah, for open, I will use anterolateral approach. I think it's enough to do most of the job here. And if you need later on to repair the medial ligament, you can do it through medial approach.
Very
but
good.
I have just a concern for arthroscopy, and I would like to ask Nasef as well for this technique, because I used ankle arthroscopy with ankle trauma in some patients for isolated medial malleolus fracture, not such complex injuries. So is it worrying to do arthroscopy with syndesmotic diastasis and the possibility of extravasation and having some problems with extravasation of fluid, especially with such significant trauma?
This is always the concern for anyone who is going to do this is always the concern for anyone who is going to be doing arthroscopy. But if you're doing arthroscopy in a fracture case, there are, of course, you know, Ossama, and I think this is more, you asked me for the audience, you are more apt to have certain criteria. First of all, you do not exsanguate the limb. You just do a compression bandage with elastoplast or a very high compression. You do the incision of the arthroscopy through the compression band. You do not use gravity, except gravity inflow, and preferably even without gravity. So it's just the washing out, and you look almost as if it is dry, without definitely no pump. And as a third option, or a third precaution, you have to use the 4.0 scope. Not, I don't use the 2.7, but routinely some people are afraid they use the 2.7 scope. The good side is that it does not get an outflow of water enough from around the cannula or the obturator of the scope. But the bad side is the amount of the fluid pressure coming out is so much reduced because it's a 2.7 scope, so it's very small, so you do not get to see much, and then your procedure is lengthened. And this is the fifth point. You have to be very, very quick with the scope to prevent that complication. And as much as it has been heard about that there is extravasation with ankle fractures, as much as if you go even to literature, you find that that incidence is just heard about. It's a taboo, but you don't really see it in real time practice.
Yeah.
I hope I
دكتور
answered
أحمد
that question.
أنا ظاهر ممكن أسأل سؤال.
اتفضل يا باشا.
ناصف دكتور ناصف. I want to know exactly what is the role of arthroscopy here, because now I am going to open the fracture. We all agree that it's going to be an open reduction. It will not be reduced by an arthroscopy or whatever it is. So we need an open reduction. I have to visualize the joint
Yes.
As much as I can. So why to do an extra step?
Yes.
As long as I am going to open it.
In this particular case, there is a very evident impaction fracture on the anterolateral part of the tibial plafond. It has taken out the anterolateral fragment and it has comminuted that part, as you can see from the CT. And in addition, it has done a shear fracture on the lateral side of the talar dome, as you can see from the CT here. Now, this impaction fracture with a lateral deviation has definitely caused small loose bodies to be intra-articular. The incidence of seeing these in the dome, above the talar dome, open is much, much less than if you have introduced the scope and you can actually see and pick out. This is the first thing. And we know that the amount of intra-articular debris, osteochondral fragments that you leave inside is directly related to the arthritic process that might happen not in 5 or 10 years, in 2 to 3 years' time. The other thing that you can use the arthroscopy for is to evaluate the syndesmotic part of your fixation. This you are not going to open. Even if you open to reduce the inferior tibiofibular ligament, the AITF ligament, you will not be able to see with the scope underneath into the syndesmosis. So you turn the scope and you look, and you will see on the axial, I'm sorry, Dr. Ahmed, if you can bring the axial CT again, you will find that there is a fragment intrasyndesmotic there. You can see this part here. And this you will not be able to remove openly. You will not be able to see it because there will be the incisura of the tibia preventing you. So these are the two main parts. The last thing is sometimes in this case, if you open anterolaterally, try as much as you can, there's a fracture of the fibula. Sometimes if you find, because there is there's a lateral talar shift, the deep part of the deltoid will be incarcerated and bent in. It will save you the time. You will know you can open the deltoid immediately, take it out of the gutter, and then your reduction will be easier. This, for me, is the reason of adding an extra step in this specific situation.
Well, to be honest, very good things that you have raised. Actually, I did not do, I'll tell you my verdict, Dr. Nasef, because I opened anterolateral approach as you have all agreed. And this gave me an access to the whole anterolateral. Of course, you need to be careful about the superficial peroneal nerve. I look after it. And then I had a very good look. I went through this fracture site to go in. I looked into the joint through the fracture. I had a good reduction in the debridement. Some loose fragments I had to take out. And in the sequence of fixation, I had to fix first. First, I
في صوت بس في صوت يا جماعه يا ريت البارتيسيبانتس يعملوا ميوت اول بليز يعني all participants should mute their sound.
Okay, Khedr?
I'm going to mute all now, and then you unmute yourself as presenter. Okay.
Okay.
Good. Okay. Go ahead.
سامعني دلوقتي؟
تمام.
Okay. The sequence of this is what I have done. I went through the anterolateral approach. If you can see it, I used two plates. طبعا I would fix the tibia before the fibula. The fibula is the last one to be fixed. I went through the fracture site. عملت curated وشلت. طبعا fragments كانت صغيرة جدا. I couldn't even hold it. عملت البليت دي as a buttressing plate to the fragment of the Tilo chapeau fragment. وعملت internal fixation by just by KY زي ما حضراتكم شايفين هنا في هربرت سكرو. يبقى ثبت التيلر فراكشر by Herbert headless screw. And then I went to this fragment. I did it first and then put this buttressing plate and then I fixed the fibula. Of course عندنا syndesmotic injury فعملت كده. Once I did this, as you can see, the medial clear space has been reduced. So I think I was lucky enough that I did not have this medial clear space or incarceration of the deltoid ligament. This is the post-operative X-ray. You can see here one plate, just one third tubular عادي جدا. I put it here with just, you can see buttressing ماسكه two screws only. Just it's a buttressing plate وماسك هنا الفراجمنت وفي اللاترال view you can see this fixation done. طبعا بعد ما جالي في الفولو اب I needed to remove this KY because he is very active and he wanted to get it removed. Then I removed في حته طبعا a small fragment here we lost اللي كان فيه comminution جامد جدا. As you can see here after 3 months or 4 months I removed the syndesmotic screw and I removed the K wire. Luckily enough he did not have any instability here about this for the medial side and he has done very well. ما اعرفش كان رجع
ممكن تبقى تفتح النت يا احمد على البلاي ستيشن
as a police officer and he's doing very well. بس ما اعرفش اذا كان بيقدر ينط بقى حاجات كتيره. Any comments about the procedure?
Yeah, did you start with the fracture talus first to make use of the room and this?
I tried it الدنيا لان اول حاجه لان الفيو بتاعك بيبقى اوضح وانت لسه قبل ما بتريديوس التيبيا بلافوند. ف the first thing I did بعد الاكسبوجر والديسكشن I fixed the talus. وبعد كده I went sequentially للبلافون تيلو شابو and this and then I went this is the last one to be done.
Okay.
انا ممكن ليا كومنت هنا.
اتفضل.
معلش can you elaborate more about the approach itself? You have said you have to look for the superficial peroneal. ازاي how to find it because and if it is cut what do you do?
بص هو السوبرفيشال بيرونيال بيبقى ماشي along لاين على الانترولاترال سايد بتاع الانكل كتير قوي بتشوفه. يعني انت لما بتعمل بلانتر فليكشن وانفيرجن بتحس النيرف كده it can be seen. يعني بيبقى ليه علامه سيرفيس اناتومي كده يعني مش عارف من الجنكشن ميديال سيد او اللاترال سيد.
Ahmed,
ايوه.
would you keep in English please because we have some non-Arabic speakers.
Really? Okay, more than welcome. Okay. So the superficial peroneal, I always think it's always in my, I think it's in my, I do dorsiflexion of the nerve, longitudinal incision, make all my dissection on the longitudinal way to avoid, I try to avoid transverse dissection by any means to avoid cutting of the nerve. But this nerve actually, it can be palpated or can be felt. If I have a neuroma, if I incidentally cut it, I just drag it and just try to bury it under in the muscles, like the peroneal muscles or the muscles, the anterior compartment of the leg, because the neuroma is sometimes painful. So I try to bury up in the muscles.
Post-operatively, Ahmed, what will be the situation here?
I try to encourage him to do early active mobilization because early range of motion is very important to avoid ankle arthritis. So أنا بعمل له I do posterior slab for a couple of weeks, and then if the patient is compliant, I put him just in like air cast, and I advise him to take his foot out of the air cast and keep moving it every now and then to allow early active mobilization, because actually the final goal of this internal fixation is to give him a very good mobility range of motion, because the fracture will heal by any way. Any other comments? Any other things that could have been done?
ممكن اقول حاجه؟
طبعا يا باشا.
انا شايف في الاكس راي اللي موجوده دي بوست اوبراتيف او يعني فولو اب ان لا لو خدنا من هنا هنلاقي ان الفراجمنت اللي فيها الكي واير is absent, is not there. disappear. اللي هي المفروض انها buttressed by anterolateral tibial. Was it absorbed or have you removed it or it's not apparent in the X-ray؟ مش فاهم. هنا بالظبط في الاكس راي دي ايوه مكان الكرسون هو موجود كده، المنطقه دي الكورنر ده is empty. انا الحقيقه I'm not worried about this corner maybe empty or so long that the ankle is stable. لان الحته دي اعتقد انها الافضل انها تبقى empty عن انها تبقى فيها كالس او exuberant كالس او osteophyte. وانا اعرف انكم بارثروسكوبيكالي you always remove the spares من الريجون ده او اللوس بولز من الحته دي من غير without harm. So I'd like to ask you, did you remove this fragment while you were removing the KY, or just it was absorbed or had disappeared? And then if so why not to remove this two holes plate which is there now?
This buttressing plate?
Yes, because it's not buttressing the fragment now.
Yes, I kept it for some time, but I actually came again and I removed all the implants about 8 months after the surgery, because I came out, I just did not feel that I need to take this out at the moment. But you have a point, Professor Hazem. It was not doing a job now because the fragment has been absorbed. But I just went as a minimal fixation, just took the K-wire off and took the syndesmotic screw out.
But you think that the fragment which was fixed by the K-wire is absorbed, or have you removed it?
I did not remove it. No, I did not.
It was absorbed.
I think it was absorbed because I did definitely. I went in. I just took the K-wire off and took the syndesmotic screw off. I did not. I did not find anything that needed to be removed, or did not feel that it was loose, that it needed to be removed. No.
Probably it was absorbed.
Most probably, I don't know. I think I was lucky, but by being absorbed, because otherwise it would be like a loose body. But it was absorbed, and he sustained a very good range of movement.
Okay.
Dr. Kholeif, we have questions from the audience.
Okay.
Did you use one or two approaches?
Only one approach, anterolateral approach, to expose the ankle and the talus and the fibula. Only one approach.
Yeah, the second question, that if you are going to repair the deltoid ligament, would you do this before or after fixation of the syndesmosis, and why?
I would do this after fixation of the syndesmosis. I would do like a stress test and to see if the talus, a valgus stresses, and to see if the talus is just opening up and the medial space is opening up or not. But if not, I wouldn't go in and repair the deltoid ligament per se. I would leave it as it is. Some people might not agree with me, because some people say that if he's active and you need to go in and to repair the deltoid ligament. But I feel that if I have done the syndesmotic fixation, the ankle is stable and there is no lateral talar shift by stress, I wouldn't want to fix the.
Yeah, and I think we will come to this debate probably in the next cases. So probably the next point to be discussed.
Any other questions?
Yeah, another question. What was the time for the removal of the K-wire and the syndesmotic screw?
I took them 3 months later.
3 months.
3 months. Maybe this is why it has been resorbed or something like that, but It was 3 months, and the whole thing I took it. Took the whole implant, except of course I left the Herbert screw. I didn't take it out, but I took the plates and everything. Took them about 8 or 9 months after, because he was very keen to return back to his original activities.
Yes. Thank you, Dr. Ahmed.
Thank you very much. So the take-home message: you need to have a very careful assessment of very high velocity injury. As you can see, the initial X-ray was actually very innocent, but what is hidden behind was much more sophisticated. Pre-operative planning, I think, is very important. The approach, the reduction plan, which to come first and which second and which third. Implants need to be available, especially I had to order this Herbert screw or headless screw before the operation, otherwise I would be in trouble. Sequence of fixation, as I told you, try not to do a fixation that will prevent you from fixing another fragment. So I started with the talus, which is the hardest thing to reduce before reducing anything, and then I went up to the plafond and then the fibula. Of course, early rehabilitation, as I told you, I kept him in slab for 2 weeks and then started early mobilization. But of course, weight bearing has been delayed to 6 to 8 weeks after this. But early mobilization, non-weight bearing was very essential. And I would thank you very much for this.
Thank you very much, Dr. Ahmed. Thank you very much.
Thank you very much. Now we move to the next case, and it's going to be presented by Professor Nasef, Mohamed Nasef. So Nasef, please share your screen.
Okay, is it apparent now?
Can everyone see it? Yes. بس خليها في البرزنتيشن مود يا دكتور ناصف.
Yes, I am just hold on, I am sorry.
ده السكرين.
Yes, I just wanted to make sure you can hear me, because I think
yes,
I was muted.
Yes, we can hear you.
Okay, sorry, then it was my mistake. Okay, so now it's good?
Yes.
Okay.
Yes.
Okay, thank you. So, of course, I'll follow up with Dr. Ahmed Kholeif. He had a much more interesting case than this. This is a rather simple case, and the idea, and this is why I try to combine the case with a few pertinent points, especially for our younger generation viewers or participants, so they might get some of the basic knowledge about these cases. It's not moving. Okay, I'm sorry, these are my disclosures. I do have to show them up. And so these cases, I want to define the pertinent points in the history taking that might alert our suspicion regarding a simple ankle fracture, what is called a simple ankle fracture. We should know when to use added investigations or diagnostic modalities, and how to approach these fractures systematically and in a stepwise fashion, and perhaps learn a few guidelines as how to assess if we have done a good and adequate reduction or not. Now, this is the case. So he's a 30-year-old male. He's a tourist guide. He's actually the brother of one of our radiologists, a good friend of mine. He's also an indoor national soccer football player. So he plays for the national team. And he had this injury while he was playing football with contact or with an opponent on the indoor pitch. Now, the radiologist, he sent me these x-rays and he told me, Nasef, look, it's a simple fracture. I think he's going to have a conservative cast. مش كده يا Nasef? So where would I send him? Which one of the hospitals would some of your assistants be able to cast him in? And I needed to ask him one question to be sure on these x-rays, is that possible or not? Is this case over the phone? Am I going to treat him conservatively, or am I going to ask for something else? And this was the question I asked. It's not moving again. Okay. I asked him, when he had the injury, did the people around him, his teammates, what was the position of his foot? And they said, no, it looked really bad. They had to correct his foot back to where it should be. And that's when I said, no, this does not look like a simple injury. And so why is that? Because of the classification. We all know this, we are not going to discuss this. This is a supination external rotation injury. And we know that these are the most common injuries that we're going to see. 70% of your ankle sprains or fractures are going to be the supination external rotation. And we know the classification, I won't go through it. But what I would like to draw your attention to is, although stage 3 is said to be stable, and we can discuss this later as, in between us as a panel, but this involves the posterior malleolar fracture. So is it really stable? But what we are concerned with is the unstable, is the type 4, the stage 4, because this differentiates the oblique lateral Weber B's. If it has a medial malleolus, of course, it's now a bimalleolar fracture. But if it has a deltoid, then it is also considered unstable. So comes the question, is it going to be treated conservative with these x-rays? And I would like all the participants just to take 10 seconds and decide, are you still going to treat this patient with this simple ankle fracture conservatively? And what would you base your opinion upon? And those who even think that they would treat them operatively, what are the bases? On this plain x-ray and that simple history of the question, is that enough? Or would we need additional investigations? So the question, just for the esteemed panel, of course, it's much less than their capabilities, but which one of the panel would like to add a certain view or a certain investigation for these? Anyone has any specific recommendation? Dr. Ahmed, Mokhtar, Ossama?
I think I would like to have I usually ask for a CT scan for these patients. I need to see syndesmosis. I need to see all the cuts all around in order to see if there is any associated injuries.
I would like
MRI, of course, sometimes might be needed, but I don't usually ask for so much MRI.
I usually ask for something simple, the mortise and oblique views.
Yeah.
Okay, that's also a very good
mortise
idea.
view, and I would ask if the mortise view shows some syndesmotic instability, I would ask plain X-ray for the contralateral side, just to compare the syndesmotic space between both of them.
Okay.
Yeah, Dr. Nasef, I think we should do some form of stress views. I don't know in your practice,
exactly,
comparing stress views or the gravity stress views. I don't know what you like, but I think it's to consider in such to differentiate between type 2 and 4 of this type of fracture.
Exactly. So as the participants can see, what the panel is trying to look for is, yes, there's a fracture, but is there an added instability with this fracture? And to do that, you have to look for a stress view or a type of weight-bearing view to decide, is this ankle stable, supination external rotation type 2, then you would treat it conservatively. But if it's a supination external rotation type 4, having a medial plus or minus a syndesmotic injury, then you would have to treat this operatively. It becomes an unstable. So these are the stress views. And as you can see, it's a weight-bearing. I could have done the CT, I could have done MRI, I could have done stress views on a fracture, maybe, but I actually had the patient with the fracture standing. And these, as you can see here, the medial space opened up, and we'll show it in comparison. The talus shifted. You can see the tibial plafond with the talar, and the syndesmosis shifted. And these are the comparative views, as you can see, between the non-weight bearing and the weight bearing. So now I know that I have a unstable fracture. I still don't know what is exactly unstable. Is it the syndesmosis? Is it the deltoid? Is it a combination of both? So
Dr. Nasef.
Yes.
And if the patient can weight bear and you can do an X-ray, I think there's some sort of stability, because I can, in the mortise view, it is not that clear that there is some shift or the clear space is obvious. I can but a patient who can weight bear on his ankle, which is already fractured, that's maybe can give me a clue.
I will come back to this in just 2 slides from now, and there is evidence behind that. But that's a very, very good point, Dr. Zahar. So as we said, we want to detect the stability. Is it a supination external rotation type 2 or is it type 4? Like Dr. Ahmed Khedr said, one of the most commonly used are the weight-bearing views. Now, these are very easy. You can have the patient on the same wheelchair. He doesn't have to stand, and he can show, and you can take an AP of the ankle in direct AP hanging from the side of any table, and this would convert what you would think would be a stable fracture into an unstable. Other proponents are the proponents of the standing weight-bearing views. Now, like Dr. Zahir said, some authors decided that if you can walk on it, if you can stand on it and bear weight, then it's probably stable. But actually, this was not shown to be true. But like Dr. Elshazly said, it's best if you get comparative views. And I'm not saying that you have to get gravity stress comparative views, but definitely standing comparative views, and definitely even if you're not going to have the patient in a fracture condition, you should get comparative weight-bearing views to pick up the subtle, for example, Lisfranc or other types of injuries. So to detect this stability, there have been questions. Some people advocate that in simple fractures, simple radiography is enough. So not the CT and not the MRI, as probably Dr. Ahmed said, because the CT and an MRI would be more significant in ligamentous only injuries. Others stated, like Dr. Zahir, that it is best if the weight-bearing X-rays, these are not indicative of medial clear space widening. And they said that the talus often centers itself under the mortise, and so it is stable by nature. But actually, this was not true, because long ago, from 2010, it was defined that the weight-bearing X-ray, if the patient can weight bear, is better than the gravity view, and this is because of this simple idea. In the gravity stress view, the ankle is plantar flexed by definition because you're getting it to be along the gravity. In this position, you see, this was a gravity stress and this was a weight bearing. So the unstable became stable. But that is the paradox. This is because the posterior tibio-talar ligament, which is the most strongest of the deltoid, is the tightest when the foot is in neutral. So when the patient is standing on it, meaning if the patient on weight bear, if the talus shifts, then you definitely know you have an unstable type 4B, which is a difference. 4A is a partial tear of the deltoid. A 4B is a complete tear of the deltoid involving the PTTL. So in my point of view, and in some other authors, the weight-bearing X-ray, if the patient can bear weight, is a better view to demonstrate the stability, and hence your method of fixation for these patients. But again, is this a sure sign of syndesmotic injury? Is the standing X-ray with an opening and a medial opening, is it a sure sign of an instability? And have you, by this X-ray, diagnosed, is it a deltoid injury, partial, 4A or 4B? And this is why we need to know the stability of either to know how to progress with the fixation. So now that we have done, for example, the standing or the weight bearing, is this enough? Would you still, Dr. Ahmed, want to do a CT? Dr. Ahmed Kholeif?
No, I think you get the information now.
Yes. Would anyone else of the panel want to do any additional information? Any additional?
Yeah, and Dr. Nasef, according to what you have said, that the weight bearing is not a good sign of stability, because not, but it is a good positive, but it is not a negative.
Actually, Dr. Zahir, it's the opposite. The gravity stress is not a good positive, but it's a good negative. The weight bearing is a
weight bearing. I'm talking about the weight bearing. Weight bearing is a good positive.
It's a very good positive.
Yes, but if it is negative, does not exclude instability.
Yes, but no, if it is negative, then the patient is stable.
Okay, so it is good positive?
Yes, and it also excludes that the patient is unstable.
Okay.
Of course, if you want to take it a step forward, you can at that point. If you want to be sure you are going to treat the patient conservative, you can at that point in time do the added expense of the CT, look at the syndesmosis and detect if there's any talar shift. But also papers have said to do that, you need to do a comparative CT of both sides. So actually, and I know Dr. Zahir, you're probably going to kill me, but I also decided I would need to do an arthroscopy. And I'll show you what I meant. I wanted to make sure that what I am seeing on the X-ray is unstable. So I looked at the syndesmosis, made sure that I could open it more than 3 millimeters, which is now the recommendation. And if you notice, these X-rays were in 2016. So this incident, this happened in almost 4 years ago. And I also detected that the syndesmosis is unstable in both the coronal and the sagittal. So this was the addition of the arthroscopy. And I will show you in a few more slides if there was another value. I know that we can debate, is the arthroscopy of value or not? I believe it was in this particular case, even though there are no other injuries, but it decided for me the stability of the syndesmosis and the stability or otherwise of the deltoid, and I'll show you in a while. And this is a very nice article. It's a review article. It came out in 2018, and they decided that MRI 3 Tesla in the plane of the syndesmotic ligaments is the investigation of choice for ankle syndesmotic injury. However, in the presence of associated injuries like fracture, arthroscopic viewing with stress examination during the arthroscopy is the diagnostic benchmark. And this was a radiology paper. So it showed that up to that extent, they are not sure of their own radiology as opposed to a arthroscopy. And of course, that changes the picture. So what about the syndesmotic injury itself? As you can see here, there's a hook test that is being done, and at the same time checking. This is another case. And we also wrote up something about the direction of the instability, because it can be, the syndesmosis can be in any one of these 3 planes. And to detect this deltoid injury, I personally, while growing up, I was taught swelling, ecchymosis, medial tenderness, or even the lab Hansen classification. And this has been proven almost 10 years ago now that they are not adequate predictors of the integrity of the deltoid. You still have to look at the deltoid end on or at view to know if it is completely cut or incompletely cut, because that is going to define the stability in this supination external rotation injury. So now that we have decided that perhaps this is an unstable injury, we are going to go for a fixation. So what is the operative technique? Would you fix your fibula first? And when would you decide to approach the medial side first? Anyone from the panels has any idea? Has any suggestions, I mean?
Dr. Nasef, sorry for the interruption. Just please disable attendee annotation, because
Yes.
From the options above their view options, and then you will have an option to disable attendee annotation. Thank you.
Yeah, sure. I noticed, I thought my computer was doing crazy things on me. Okay, disable, annotate. Okay, more. Okay, yes, I found it, and I'm sorry, I've done it now. Okay, so for sake of time, panelists, would you, in any particular case, approach the medial side first?
Thank you, Dr. Nasef, for this very nice case, because in my experience and in all our experience, it's a very common mismanaged injuries.
Yes.
I usually start from the lateral side, except if the talus is not reducible in the mortise. If the talus is not reducible, then the deltoid ligament is inverted inside the ankle joint, preventing the talus to be centered. Then I open medially first to clear the medial space for the talus. But if the talus is reduced, then I usually start with the lateral side. I don't know if all other panel agree with this.
Just a small question, Dr. Mokhtar. How would you know that the talus is not being reduced? Would you do that clinically with your hands, intraoperatively?
No, with an image intraoperative with image intensifier.
So you use your own manual force and try to reduce the talus?
Yes.
Okay. Any other one has any?
I do the same, but if I have a frank deltoid ligament injury with stellar tilt and shift in the same time, which is a diagnostic sign, radiological sign for deltoid ligament, before I go for fixation of the fibula, I just preliminary fix the fibula. And before I fix the syndesmosis, I do correction for the deltoid ligament first to be easy to find it and to fix it. because if you close the syndesmosis, close the fibula, it will be difficult to retrieve the deltoid ligament.
But the problem then, Dr. Ossama, is that if the syndesmosis is open and the talus is not perfectly centered, you will suture the deltoid in a lengthened position.
Yes. I mean, you preliminary suture, you don't tighten the suture, you expose the
just
deltoid,
take the suture and then tighten them at the end.
And you retract the ligament from the medial space, because if you close everything, it will be difficult to retract the ligament from the deltoid space.
Yes, this is exactly what I think. I might just add that if the supination external rotation has a very high degree of comminution, or is very, very osteoporotic bone, you cannot depend just on the lateral pillar of the fibula, and you have to reduce the talus itself in one direction, and then you build up the fibula depending on the talus back into the mortise. So in this condition, you might think about reducing, not repairing the deltoid. So in this case, I went ahead, I fixed the fibula, I brought it out to length, and I think this, especially for our junior colleagues, is the most important part. Whatever you do, you have to anatomically reduce your fibula, length and rotation. And we will see this in a while. This is the most important step. We can talk all day about syndesmosis and deltoid, but if your fibula is off-ended, if it is not brought out to length, if it is rotated, this will end up in arthritis in a couple of years, not even more. So the anatomical reduction of the fibula is the most important. And to do that, we know that we have to know the rotation by the dime sign. This is easy. Now I want to ask the panel, what about rotation? Do we now have any clue in 2020 how to assess the rotation of the fibula intraoperatively during our operation? Panel?
Okay. There is the acute fracture and the malunited fibula. In the acute fracture, I depend mainly on the anatomy of the fracture. So if the spike of the spiral fracture is in its bed, then the rotation is corrected. But in neglected cases, it's very, very difficult to preoperatively determine the rotation. So you have to depend on your sense intraoperatively. And I discussed this point a lot with many surgeons, that the problem of rotation cannot be assessed accurately preoperatively, or even intraoperatively in neglected cases.
In preoperative, and there were studies about CT scan rules in detection of fibular rotation in preoperative assessment. The challenge is the intraoperative, because you can do it. You try to guess according to mortise view intraoperative how the caesura is reduced or not. There is no definitive method, I don't think, for assessment of rotation intraoperative. Pre with CT scan, it's easy.
And this is why, of course, like Dr. Mokhtar said, if you have a fracture, it's easy. You reduce your fracture, you know that it is your rotation is better. But I came across this very, very, very nice paper in injury, and it was actually came out in 2018. And this is a method to assess rotation. We do not have intraoperative CT in Egypt. We do not have even intraoperative weight-bearing CTs, which are now the standard. So if you take this, it's a reliable method. It has been proven. It has been validated. So you take a line across the lateral talar cortex and the medial talar cortex, and this is the malleolar fossa. Now, AB, this line, should always be more than BC, and the number is almost 1.3. Now, let us take this clinically and look at the picture. If your fibula, and this is better for malunited, if it looks like a spoon, if the syndesmosis is open, and if you feel that the talus is very close to this is internal rotation. In the external rotation, it looks like a knife. The syndesmosis is too much closed, and the talar gutter looks open. This is external rotation. The normal has this normal contour and fossa. And this is a very nice paper, and I advise everyone, because this is a very easy technique. It's nice to see it intraoperative. You can use your arthroscopy, and you don't need so many sophisticated instrumentation. And okay, so now we know the fibula, rotation and length. What about the syndesmosis? How can I assess the syndesmotic reduction and fixation intra-op. And this is always a question for us foot and ankle guys. How much is enough? How much should I tighten that screw? How much should I tighten that tightrope? Panel? Dr. Ahmed, Mokhtar, Ossama? Is there a way that we know of to know that the syndesmosis is reduced?
I depend on anatomical reduction, or I try to see the syndesmosis, to expose it, to do exploration of the syndesmosis. And diamond, I'd like to, because I consider this like an intra-articular injury. So I try to check by myself that the fibula is lying smoothly in the incisura or the fibular notch.
Okay, I of course use the arthroscopy, but that is not in all cases. Don't get me wrong. I will show you now a radiology. Mokhtar, you were going to say something?
Yes, in some cases, the syndesmosis is completely dislocated.
Yes.
And you have to reduce it. Then you have to see the incisura. You have to see incisura because I saw many cases that the fibula was fixed either in front of the incisura or behind the incisura by 2 screws. So because the surgeon fixed them blindly. So you have to see if the fibula is the whole posterior, then you have to see the incisura. But in a simple case, when we call it latent instability. So syndesmosis is okay, but when you do the hook test, it moves, but it's in place, but latently unstable. In these cases, you don't have to visualize the incisura, and you can just put the screws. But if you feel that you are in doubt, I always expose and make sure that the fibula is in the incisura.
And this is what we used. If you look, if you take a line across this is a radiological also with the fluoroscopy. If you take a line along the posterior in a dead, this is the most important part, it has to be a dead lateral. So the 2 domes of the talus are superimposed as one line. This talar dome, it has to be exactly congruent with this. Now, this is a lateral view, and if you ask anyone of my colleagues who works with me as assistants, they will tell you I always drape and even the other limb. I use the other limb. Anyway, this is the posterior part of the talus, of the fibula, where it crosses the talar dome. And you can see it always has to be after, posterior to the talar tibial plafond. Not even this. There is a line which has been described ever since 2013. This takes the epiphyseal plate at the junction exactly, going backwards to the anterior dome of the tip of the anterior cortex of the fibula and crossing to the posterior part of the tibial cortex. If you take these 2 bisectors, A over B, it should always be almost equal, 0.9 to be exactly. So I'll give you an example. This is one example, exactly like Mokhtar said. It looks perfect. The patient is being told by numerous surgeons, you're fine. But look at the posterior, it's outside of the tibial plafond. Look at the lines and look at this. So this is anteriorly displaced fibula. And if you do the CT there, you can see it. It even has, it is off the syndesmosis totally. So I would also encourage most of our juniors to start using these parameters. They are very good intraoperatively, and this has always been our problem. So it's the antero-posterior tibio-fibular ratio. And at that time, I used, this was 2016, and to be very honest, I won't say I knew it. I didn't know it at the time, but I took a comparative lateral X-ray of the other side. So I have now done the anatomical fixation. I know I have done my, is this enough? Now should I close the case and finish? Panel?
Test the medial ligament first.
Yes, I have to test the medial ligament. And actually, that is what I did. Now we can debate in this particular case, should I fix this now or shouldn't I? I have fixed the syndesmosis. Why do I need to fix the deltoid? And this is still debatable. So anyway, I opened up, and as Dr. Mokhtar said, you will find it completely avulsed off, even by just, I didn't do except the skin. And the subcutaneous, I took a clamp and I pulled it, and you can actually see the talus right in front of you. I used 2 anchors, and then this is the post-op X-ray. And this was the other reason of which I did the arthroscopy. I wanted to check the medial side and know if I am going to fix it or not. And so I used the arthroscopy on the medial side, and you can see here the deltoid is completely off the medial malleus. So whatever I do, I know that this patient might end up with a pes planus afterwards. The deltoid is gone, and this is the main stabilizer of the ankle. So this is a 4B, and that's why I went with the fixation methods for the fibula, for the syndesmosis, and for the deltoid. So in the end, you can use whatever type of fixation for the syndesmosis. In an outcome of meta-analysis for the deltoid, it has been said that those who have the deltoid repaired, but mind you, this has a fallacy as a paper. It was not done on exclusively 4B cases. It was a comparison of cases with deltoid injury, just like that, general. They say that it has earlier benefit, but not long-term ratio. So this is the immediate 2 weeks post-operative. This is 6 weeks. As you notice, I do not remove the screw, but this is debatable later on. So this was the pre, and this is now, as we said, almost 3 years post-operative. We can talk about syndesmotic screw removal. We can talk about hardware removal later on. So in the end, as a take-home, there is very rarely a simple ankle fracture. You should have a high index of suspicion. Even on the phone, you can ask a simple question. You should not be afraid to use other diagnosis or investigation modalities when you want by suspicion. You should know how to reduce the most important part. Reduce your fibula. The fibula is the cornerstone, the rotation and the length. And we have to know how to assess that. Otherwise, we won't be doing the job properly, especially in comminuted, especially in malunited, like Dr. Mokhtar said. If you have both syndesmotic and deltoid ligament injuries, the ankle is still unstable. Even if you have fixed the fracture beautifully, your ankle is still unstable. And you have to fix probably the syndesmosis first, plus or minus the deltoid ligament later. Thank you, and I am really sorry if I overshot my time. I will try and stop sharing now.
Thank you, Dr. Nasef.
Thank you very much, Dr. Nasef.
Again, we're back to our moderator, Dr. Khedr.
Questions from the audience?
Yes, I think I wouldn't do much questions because probably
we're out of time.
We're out of time, but there were some questions about the weight-bearing X-rays. How do you do them? Like, do you give the patient analgesics? Do you do a hematoma block? What's your practice?
No, you ask the patient to stand on it. There's usually a bar. He's usually coming in on a wheelchair. You can give him this 4-bar, and this is how it's even done abroad. And you have him stand, and then you just pull the bar away. It takes a few seconds. The radiologist has already got the X-ray, the C-arm, and the X-ray plate in place. And he just needs to stand there for a few seconds. Some people are even doing this single stance. And you will be amazed at the amount of people, if you ask them, that can do this even if they have a fracture. Remember, it's also a bit psychological. At that point, they still do not know that they have a fracture. They are usually wheeled in because they are told they might have a sprain. So if you have them weight bearing, it works.
Yeah, okay, that's good. So I think we probably should move to the next question, to the next case. We're running out of time, and we can probably take the rest of the questions at the end of our discussion. So I'd like to present Dr. Mohamed Mokhtar for his case. Go on, Dr. Mokhtar.
Disable attendee annotation, Dr. Mohamed.
Sorry?
Disable attendee annotation من في فوق جنب view options في more disable شفت اهو ادينا
more
شخبط لك اهو
شخبط لك.
Okay, I did.
Disable attendee annotation.
Okay, I did. Thank you very much, Dr. Sri. I'd like. Okay, the screen is clear. Can you hear me?
Yes.
Yes.
Okay. I'd like to thank all the panel and all the participants, and a special thanks to Dr. Ahmed Kholeif for inviting me in this case discussion session.
Very much.
I'd like to thank
Mokhtar.
نعم.
نمسح الانوتيشن دي اللي هي
حاضر، انا هخش على بعدها دلوقتي.
ماشي. استنى بقى.
Okay. So I'd like to thank Dr. Ahmed and Dr. Nasef for their nice cases. This is another case in an ankle injury. This patient is a 37 years old male who had this closed ankle injury. So closed, isolated ankle injury, no other injury. What do you think the classification of this injury in Log-Hansen classification and in Weber classification? And how would this help us in the diagnosis and the treatment plan? So first, what's the classification according to Log-Hansen classification? Please think for 10 seconds, what would be the Log-Hansen classification of this fracture? You can cheat from this slide. This is Log-Hansen classification, supination adduction, supination external rotation, pronation external rotation, and pronation abduction. So I think after seeing this, you agree that the patient has a pronation abduction classification. So what's the difference between pronation external rotation and pronation abduction? In both types, the fibular fracture is above the syndesmosis. But in pronation external rotation, the fibular fracture is usually oblique or spiral. But in pronation abduction, it's usually comminuted or transverse. So this fracture fits more with a pronation abduction type of Log-Hansen classification. What can we understand from this? That the injury started on the medial side, because in the pronation type injuries, the injury starts on the medial side, which is under tension. So the injury started on the medial side by rupture of the deltoid ligament, then rupture of the anterior syndesmosis, then fracture of the fibula, diastasis of the syndesmosis, and fracture of the fibula above the syndesmosis. So we have medial side injury, syndesmotic injury, and fibular injury. What would be the classification according to Weber classification? It's simple. Weber A is below the syndesmosis, Weber B at the level of syndesmosis, Weber C above the syndesmosis. So this patient has a Weber C injury, which is above the syndesmosis, and this let us know that most probably the syndesmosis is injured. Now, what's your planned treatment? Please think about it. What will you do? Now, we have not a query deltoid injury like the case of Dr. Nasef. It's a classic, overt, non-equivocal deltoid injury, syndesmotic injury, and a fibular injury. So what would be your treatment?
For the panel or participants?
Dr. Ossama, تفضل.
Okay.
It should be for the participants, but I think.
Yeah. Okay.
I think
in this case we have to tackle the 3 injuries. I think the most challenging now is the fibular fracture. It needs to be properly restored and fixed in proper length. Second, we will fix syndesmosis, and third, we will tackle the deltoid ligament. So I think these are the 3 components of injury.
Yes, I agree with Dr. Ossama. Start from the lateral side, maintain the fibular length and rotation. In these comminuted cases, Dr. Nasef was asking about discussing these points. In these comminuted cases, maybe the length and rotation are difficult, more difficult than in spiral fractures. So we have to start with this, then fixing the syndesmosis, then testing the deltoid, and if the stress test is positive, we open and repair the deltoid. Okay, this comes from an expert like Dr. Ossama, but let us see what happened to the patient. The patient underwent an operation for fixation and then removal of syndesmotic screws 3 months later. And this is the plain X-ray 3 months after the first operation. Please think, what was the problem? It must be wrong. Medial clear space is widened, syndesmosis is widened, the ankle is not centered, is not congruent. So what was the problem? What was the primary mistake of the surgeon? Is it he didn't control fibular rotation, didn't repair the deltoid, didn't reduce the syndesmosis, or something else? So
I think the fibular length is the main problem in this case.
Yes, Dr. Ossama, you are right. The main problem is the fibula is short. When the fibula is short, the talus will tilt into valgus and the deltoid will fail, regardless if you repair the deltoid or not, because the bony strut or the bony support from the lateral side is lost. So the main problem here was the short fibula. The surgeon put some, Genix, something like this, bone substitute, like a whole mass, and fill the comminuted fracture with this material without controlling the length, without controlling the rotation, just to have a mass of bony union without bony alignment. So that was a very big mistake. And when the surgeon removed the syndesmotic screws, the talus tilted into valgus because there is no lateral support. How did we know that the fibula is short? There are many signs, but one of these are very easy to use. This one, you can see here, this is the talocrural angle, which is the angle between the intermalleolar line and the long axis of the tibia. The other is the intermalleolar axis, which is the angle between the intermalleolar line and the intramedullary line of the fibula. In both cases, it should be between 75 and 85. And comparison with the other side is very crucial. Here we can see it's almost 90. So it's clear that the fibula is short. So what would be your plan now? The fibula is short, the talus is tilted in valgus, medial clear space is widened, syndesmosis is not reduced. The fibula is short and the syndesmosis is not reduced. So what to do now? I think we have to go back to the principles that Dr. Ossama said in the beginning. We have to remove all this, lengthen the fibula, repair the syndesmosis, and then repair the deltoid. That would be the ideal treatment. But unfortunately, the patient underwent a second operation where the second surgeon did bony fusion of the syndesmosis. Bony fusion. Depending on that, if the syndesmosis is fused bony, it will protect the talus in the mortise. Bony fusion of the syndesmosis and deltoid repair. So is this enough? Do you think this is enough? It's not enough because, as we said, whatever you do to the deltoid, if the fibula is short, the deltoid repair will fail. So, and this is what happened with the stress view of the patient. The clear space is widened, the deltoid is failing. So the second surgeon, even the second surgeon, didn't hit the problem. He didn't know what's the primary pathology of the patient, which is malunited fibula. Malunited fibula. So what to do now? What to do? You have to go back again. We have to lengthen the fibula, reduce the syndesmosis, repair the deltoid. But now, the syndesmosis has bony fusion. Bony fusion. And we want to lengthen the fibula. This is the classic way we lengthen the fibula. Sorry?
You need to undo this bony fusion because in order to lengthen the fibula, pull it back, you need to get this undone and put this distal fragment down to its position.
Yes, as Dr. Ahmed said, we usually do an osteotomy, suprasyndesmotic. We lengthen the fibula and control the rotation, and then we fix the fibula in the new position. But the problem here is the bony fusion here. So you cannot lengthen the fibula by this method because of the bony union at the syndesmosis. So this is the classic way we lengthen the fibula. We do an osteotomy above the syndesmosis, and then we control the length and rotation, and then we put a strut graft here. So we cannot do this now because of this bony fusion in the syndesmosis. So any other ideas? from the panel?
As I said, you need to undo this fusion.
Yeah, one option is to undo the fusion, but I didn't want to undo the fusion. I didn't know what will happen if I remove the bony fusion of the syndesmosis, and CT showed complete bony union between the tibia and the fibula. So I cheated over this. I did a scarf osteotomy like this. Very long scarf osteotomy, lateral limb here, and then longitudinal cut, and then a medial cut at the level of the joint. So I left this area alone with the bony union, and then I moved the fibula down and I fixed it. And here is the post-operative X-ray, and you can see here the change of the intermallular line. The intermallular line now, this angle is now about 80, so the normal is between 75 and 85. It was 90 in the beginning. We'll show you in the next slide. You can see here the line, the angle was 90, now it's about 80. So it's in the normal range. The fibular length is maintained. Then I repaired the deltoid ligament to the medial malleolus and to the talus. And this is the X-ray 1 year after the surgery with bony union. The ankle is well aligned, and this is the video of the range of motion of the patient. So it was a very difficult case, but we would prevented all these complications if the primary management was correct. Now, I have some questions to the panel. If you don't find enough substance of the deltoid, that was my worry before I opened this case. If I don't find enough substance of the deltoid, how would be my choice?
Yeah, I think in this case, we will go for reconstruction of deltoid ligament. And we had some work, cadaveric work,
Yes.
I and you, Mohamed, in doing these. So I think it's an option to do it, yeah.
Yes.
To take semitendinosus, yeah.
Yes, that was my planning. If I find no deltoid substance, to get a semitendinosus tendon and do reconstruction of the superficial and deep deltoid ligament. But fortunately, I was lucky and I found enough substance to suture it, and I sutured it to the tibia. But then I was not satisfied because the talus was freely mobile, so I sutured it with a suture anchor to the talus, and the result was okay. The next, so the message is the primary management is the key. The patient could have avoided all these complications if the primary management was correct. So next, is it worthy? Will the patient benefit from this huge operation? So scarf osteotomy of the fibula, repair of the deltoid to the tibia and the talus, and then the patient was 4 years after the primary injury. So will the patient benefit from the surgery or not? That's the second question. If the patient is has a mismanaged ankle fracture, but you see the patient 4 weeks after the injury or 2 months after the injury, okay. But if you see the patient 4 years after the injury, so is the ankle already arthritic? Will the patient get use of the operation? Or will the patient anyway need fusion? That's a very important question. So I think it's worthy. I will ask the panel later about their experience in these cases, because I'm sure you see a lot of cases. But the evidence, this is a very important paper in the literature, the most important paper. It was published in the JBJS British in 2010. What's important and characteristic for this paper is the interval between the injury and reconstruction was at a mean of 21 months, so almost 2 years, and up to 9 years. So the most patient was 107 months after the injury. So a very long duration between the primary injury and the definite reconstruction. This is number one. Number two is that the minimal follow-up was 10 years and up to 27 years. So you can know now that if you see a patient late after the primary injury, and you want to know what will be the long-term result of the patient. So not 6 months after the operation, 1 year after the operation, no, at least 10 years after the operation. So what did they found? Found that 85% good to excellent result. The long duration between the injury and reconstruction was not a contraindication, but was associated with a less favorable outcome. But this outcome was clearly better than a fusion. Also, the presence of early preoperative arthritic changes was associated with a less favorable outcome. So it's a less favorable outcome, but is clearly better than a fusion. So don't think a lot. If the patient has a reasonable ankle and reconstructable ankle, you should go for reconstruction. But you have to analyze all the deformities and go and correct all the deformities. Another study by Giannini, they had 22 patients with a mean interval between injury and intervention 22 months, so almost 2 years also. But the mean follow-up was 5 years, so not very long follow-up like the first study. So 10 patients were excellent and 7 were good. So 17 cases were good to excellent outcome, and only 2 patients required fusion. So this is also a good evidence that late reconstruction of malunited or mismanaged ankle fractures have good results and can prevent later fusion of the patient. Now, as we all agree, the most important point is prevention. And prevention is to do the primary operation well. So if we know where are the most common causes of reoperation, then we take care. This is a very important study that analyzed what was the cause of revision in the cases of malunited ankle fractures. So do you think medial or lateral?
Lateral.
Lateral. Yes, correct, Dr. Ossama. Yes. So syndesmosis and fibula were the most common causes for reoperation. We always say fibular fracture is extra-articular, is no problem. Medial malleolus is intra-articular, has to be anatomically reduced, and so and so and so. This classic teaching in ankle fracture. The fact is, most cases of mal reduction and malunion come from the lateral side, syndesmosis and the fibula. So please take care of the syndesmosis and the fibula in the primary treatment. So a take-home message is ankle fractures are not always simple. As Dr. Nasef said, they maybe look, and Dr. Kholeif in his case, they can look very innocent in the X-ray, but when you analyze the data, you find a lot of injuries. I have cases, maybe I write this in a series if you have similar cases with medial ligament, lateral ligament syndesmosis without any bony lesion. So only pure ligamentous lesion like the multiligamentous knee injury. I have 3 cases till now, medial ligament, lateral ligament, and syndesmosis. So it's not only the bone. You have to think thoroughly about the ligaments. Best results come from early perfect management. Mismanagement is most commonly lateral, and it's always worth revising a mismanaged ankle fracture. Thank you very much, and I'm happy if you, the panel and participants have any questions or any comments from the panel about the management of the case or the review of literature.
Thank you very much, Professor Mohamed Mokhtar, for your very nice elaborative case. I just want to, when I find a community fibular fracture, the syndesmotic injury, I know that I am having a hard job ahead of me. Because if you have a comminuted fracture, then you have a no reference reduction. Anatomical reduction will not be possible because of the comminution. You can expect shortening, you can expect rotation. And I know for sure that I need to expose the syndesmosis because I need to put it back to its place. So I know that I'm going to have a channel. If it is a higher fracture, so I know that I'm going to expose it higher up and go down, expose both, and do a lot of effort to get it back to its position. This thing, when you find something, think about it in depth and go for it as much as you can. I think this is a very important.
Can I ask a question, Dr. Ahmed? Just one question. what is your criteria of assessing the talar dome arthritis in these malunited cases? For sure, if there's an arthritis or a part of our arthritis, because these talar domes are usually tilted. So there is an erosion usually on one side rather than the other because of this shortened fibula or malrotation.
And talar tilt.
Yes. What is your method of assessment to say, yes, this patient, I will go for a derotation or a restoring of length, or no, the ankle is doomed, I need to do an fusion, for example?
Okay, I think it's a very good question and very difficult point, because there is no black and white.
Yes.
It's something like general assessment of the patient. So if the patient has good range of motion, that's a good sign of me. Painless range of motion, good sign. Painless walking, but problem only with running or prolonged walking, good sign. If the standing X-ray, there is still joint space, it's okay. If I have a luxury to do an MRI, I would do, but in most of the cases, there are implants inside, metal implants, and you cannot rely on MRI because you cannot do an MRI. CT scan, I don't find it very, very helpful in assessing arthritis, but in assessing syndesmotic malreduction. So in these cases, I usually, almost always do a CT scan for assessing the reduction, but not arthritis. I depend mainly on the clinical assessment and standing X-ray on assessing the patient. If you have any other comments or any other tricks, please tell us, Dr. Nasef.
Can I just go in?
اتفضل يا باشا.
I'm just talking about the point of becoming hesitant about reconstruction or not when I'm suspecting the presence of arthritis. And this is applied for whatever joint we would like to operate about, knee or hip or whatever. If we don't have sure evidence that this joint is arthritic, then we have to give the patient the chance of a reconstruction of the anatomy. And by the word reconstruction of the anatomy, I don't mean that we do joint replacement. I mean reconstruction of the anatomy in a sense of like what Professor Mokhtar have done, a kind of lengthening of the fibula, a kind of studying the anatomical abnormalities or the anatomical malpositions of the components of the fracture around, and trying to do a kind of osteotomies around to correct again the level of the joint, or to correct, for example, the plateau of the joint or whatever. So long that we have no sure evidence that this joint is arthritic, this is the right of the patient to try to reconstruct it. And the patient is not going to lose anything, and also you are not going to lose. Either he will win the anatomically working joint, functioning joint, or if he developed arthritis, he is going to furnish a good plateau for replacement, whether it is the ankle, the knee, the hip, elbow, or whatever. This is my opinion. This is my opinion in a kind of the humble experience I have. Thank you.
Thank you very much, Professor Hazem. Definitely, this is a very important criteria that we need to restore the anatomy as much as you can and to give the patient the best out of his condition. Don't rush immediately to arthrodesis or joint replacement, because the value of keeping his original joint was definitely much better for the patient, especially in a younger age. Thank you very much, sir, for elaborating this point. Now shall we proceed to Professor Ossama Elshazly, who is going to talk us about the ankle fractures in diabetics. Very sensitive issue.
Okay, thank you, Dr. Ahmed, and thank you all the panel and all the chairpersons for this nice webinar. It's continuation for what Mohamed has said in his take-home message. We have to always to consider doing reconstruction rather than going to arthrodesis or fusion or abolishing the joint for any kind of trauma. And we will see here in these cases of diabetic fractures another also point of view of management, which I hope will reach all of you. The learning outcomes of these lecture will be to differentiate between two kinds of diseases which we see usually in the ankle joint, if we have ankle fracture in diabetic, and if we have Charcot arthropathy, and also to understand an algorithm for management of fractures in diabetics. Let's move for the first case history because we run out of time. So I will try to simplify the communication. I will give you some choices for each question, and I want you just to chat with me or the attendees. You can chat, use the chat box to tell me your answer. This is the first case. She is 62 years old female. She's diabetic. She has uncontrolled diabetes. She was just simply falling downstairs one day ago, just 2 steps of the stairs, and she went down, and she had a swollen, painful ankle, and this is the X-ray of the patient, as you see here. After that, when we examined her, we found deformed ankle, and we have intact pulse. We have swollen ankle. The examination of skin shows diminished pain sensation for this patient, hypoesthesia in most of her feet. So my question to you, are you able to classify this injury based on the previous lectures first? So can you tell me what kind of Weber classification for this injury? Okay, can you write down in the chat? Weber P, okay. And what kind of Log-Hansen classification? Can you write down in the chat? Yeah, supination external rotation, nice, okay. So we have supination external rotation and we have Log-Hansen classification. Okay, do you need any further radiological investigation for this patient, or you are satisfied with management of this case like that? Well, I see Emil here say he wants to do CT scan, and I do agree that CT scan is important in this case because it can show us more details about the fracture, especially the medial malleolus, which looks comminuted, and I want to see how much comminution present in the medial malleolus. Also, I can see the syndesmosis, of course, in the axial cuts. In these CT scan cuts, we don't see too much comminution, and it can bear 1 or 2 screws even, and we have the fibula is comminuted here like that. So as you said, it's Weber type P, and it's Log-Hansen supination external rotation. So are you going to classify this injury as stable ankle fracture or unstable ankle fracture? So can you choose A or B? B, okay. It's unstable ankle fracture. All of you agree this is unstable fracture. That's nice. Okay. So do you want, before going to management of this patient, do you want some additional investigations to do for this patient? Like
neurological examination.
Neurological examination, we could find that diminished sensation, but the proprioception is intact for this patient. And there is diminished sensation, pain sensation in the foot of the patient, but the proprioception is okay. Okay, Dr. Hazem. Any, yeah. I see most of you asks for lab investigation. So I will show you the lab investigation for this patient. The hemoglobin of the patient was 9.6. White blood cell count was 8.6. Random blood sugar was 142, but the hemoglobin A1C was 9. And echo shows good function of the heart. Echo ejection fraction was 76. And duplex was done for this patient, showed mild atherosclerosis, and the ankle breaker ratio was just 1. So my question to you now, what is the further management we are going to do for this patient with Weber classification, type B, supination external rotation injury, and with uncontrolled diabetes over the last 6 months, as shown by hemoglobin A1C, and she doesn't have any signs of infection or something like that. Let's give you some options, and please answer me in the chat. Who is going to do the no-touch technique, never touch? Because I see this concept in some cases, don't touch surgically, just do casting for this patient. And who will go for open reduction internal fixation with rigid extra fixation? And who will go for something in between? Just he will put some screws or K-wires in the medial malleolus, and he will put a K-wire or something like that to align the fibula. And who will go for ankle arthrodesis for this patient which has diabetes and uncontrolled diabetes? Well, I see some people want to go for fixation. Some people want to go for percutaneous fixation. I'm happy with these people. And some people want to make external fixation. Some people want to do casting, and no, only one person wants to do casting in the chat. So I think most of you have chosen open reduction internal fixation, and I totally agree with open reduction internal fixation. This is unstable ankle fracture which needs fixation, and we have a diabetic patient. She was uncontrolled diabetes, but and still uncontrolled diabetes, but she is acute fracture. This is not a case of Charcot, and as a concept in doing management of fractures in diabetic, acute fractures in diabetes should be dealt as normal person with extra care. If you are going to make fixation with 1/3 tubular plate for this patient, if he's not non-diabetic, you have to use more rigid fixation if she is diabetic. If you are going to make early with bearing and range of motion for non-diabetics, you have to make delayed with bearing and more time of immobilization for this patient. So as a choosing, or the right answer is to do open reduction internal fixation for this patient. The question is, are you going to do that quickly, or you are going to do postpone for some time? And I will ask you some questions. When do you do surgery? Will you wait just for optimizing the skin conditions until you have wrinkle sign and this? Are you going to make hemoglobin A1C 7 or less before going to surgery? Are you going to make something for ischemia management for this mild atherosclerosis? Or are you going to correct random blood sugar to be between 160 and fasting to 110? Which answer is correct for you?
دكتور أسامة.
Yes.
ممكن أسأل سؤال كده بس بعد إذنك؟ ممكن نرجع شعر لورا؟ معلش أنا آسف.
اوكي.
أنت دلوقتي الكاستنج ده سؤال بيتسأل وحتى أهل العيانين هيسألوه يعني. كسر زي دوت. اوكي فعيانه عندها حاجه و60 سنه 70 سنه
72 yes
72
yes
لو انا حطيته في جبس if I put it in a cast
yes
what is the problem?
The problem for this
if it is even if it's going to unite at this position at 72, so what will be the problem?
Okay, this is unstable fracture. First of all, it will not unite. It will take some time until unite, and during this time, with the cast you have put in, she may develop ulcer on the lateral malleolus, and this is the most common scenario. These fractures usually will displace more because it is unstable. The patient has diminished sensation in his feet. He may stand and he doesn't feel pain, and he will walk on the cast. He will never be compliant for you, and he will start early with paining most probably. And this fracture will not unite. It will take a lot of time. It will displace. It is unstable fracture. So management of unstable fracture ankle is different from stable fracture. If the same patient with single malleolus fracture, with no ligaments injury, I will go for cast. But if a patient with bimalleolar fracture, even if he's diabetic, and the patient has history of trauma, she was before that totally normal. She was totally normal before that. In this case, we have to think in fixing and preserving the joint of the patient. Why should I put the patient in a cast? What are you afraid from? You are afraid from infection? We can control infection by using antibiotics with surgical time and all of that. Are you afraid from insensible skin? Okay, we do in Charcot patients aggressive operations of fusion ankle, fusion subtalar, and skin complication is not that common as we will see in literature. And I think the panel also can share with me their experience about that.
I'd like to add a point,
yes,
Dr. Ossama. I agree with you. In the Dr. Zahir, if the patient is diabetic and neuropathic like this patient and was managed conservatively, most probably it will go into Charcot arthropathy. And the management then will be ankle fusion, which is a more extensive surgery with a less favorable outcome.
And in a bad situation, you will do
in a bad situation and less favorable outcome. The best result for these patients, if they are managed by extra rigid fixation, prolonged immobilization, there is a failure rate. But if this succeeded, it is the best option for these patients to keep a normal joint and to avoid multiple surgeries. In my experience,
I agree totally that it needs an operation, but that's the discussion we usually have with any patient that is relative when you have a 72 years patient.
Yeah.
So that's the discussion we get, and you are, as you have said, you are going to have. As you have said, you are going to have to. She need to be immobilized even after the surgery, and you are going to put it in a cast. So for why from the start? Why not as a cast from the start?
Yeah, because it's unstable fracture.
I know it is unstable, but sometimes in unstable you can put them in the cast, well molded cast, and do the reduction. But it's a debate that we always face.
Sure.
I keep telling them that she will be suffering for the rest of her life if we don't treat it the proper way. She will keep suffering for the rest of her life, and whatever we do after that, we will never have a favorable outcome out whatever we do.
If I may add, well, it's the same like everyone said, Dr. Zahir. The principles of fixation of fracture are applied to diabetics as long as it's an acute fracture. If it's a stable fracture, you can go conservative. If it's an unstable, you have to fix. The only stipulation in diabetics is like each one of them said, you have to have what is called a super rigid fixation. So if in a normal patient, non-diabetic, you would put in, for example, 2 screws, in a diabetic patient, you would put 2 screws and a plate. For example, if you're going to use a small plate, use a high plate for the diabetic. Yes, you will be casted afterwards because your non-immobilization is another stipulation in a diabetic. The chances of a patient ending up with a Charcot joint in an unstable fracture in literature is up to 80% if it is just casted alone. And that is without addition of the peripheral neuropathy according to the 12 signs we know. If the patient is fixed, she has almost the same with a point, I think the number, if I'm not mistaken, is a 0.3 to 0.5% increase as a normal non-diabetic person. So you are giving her the better chance by fixing a non-stable fracture.
Yeah. Okay. So the same question, Dr. Zahir, I had from the relatives of the patient and from the patient herself, especially she is a well-educated person and her family have important members, and they were arguing with me about the possibilities of casting and what is wrong with casting, and the same answers as said by my colleagues. I told them about that, about the possibility of Charcot, possibility of developing ulcers with these cam walkers or with these casts. Ulcers usually develop with these unstable fractures. So back to our slide, the timing of surgery usually for this patient, we, as the patient doesn't have serious ischemia and just mild atherosclerosis, we went for just optimizing the skin condition until the edema subside and until controlling the random blood sugar and fasting blood sugar only. Controlling hemoglobin A1C takes long time, and this is not appropriate for these cases. So you have just to optimize the skin and this one. And we did, as we said, fixation of the fibula with extra rigid plate. If you know this is anatomical locked plate, we use it because the patient osteoporotic, I want rigid fixation, and the medial malleus took 2 screws, and the patient had a follow-up regimen with extra care and immobilization. So if I ask you how long follow-up for such patient, For me, I wait for at least immobilization and non-weight bearing for 8 to 10 weeks post-operative to avoid breakage of screws or refracture or something like that. And this is the follow-up of the patient after fixation. And here is the walk of the patient after fixation, after removal of cast at the end. And she went very well with preservation of the ankle without any problem. And she is walking on her feet. So this is one case, and the first case I want to show you about fracture in diabetic. I will give you another story for another patient. She is 65 years old. She was also diabetic, uncontrolled. She had twisting, just, she told me it was just simple sprain happened at her home 1 month ago. I just a twist. But after that, she started to develop progressive deformity of the ankle, and the ankle was swollen, erythematous, and she has mild pain. Even when I ask her to move to the couch or the bed of examination, she steps on her injured foot, and she has mild pain and insensible foot. Of course, if I ask you, how do you classify this injury? So I want my attendees to just write, write email. It's, is it unstable ankle fracture, or it is Charcot, or it is Piedmont fracture? Of course, all of you will ask it is Charcot. So the question is how to differentiate between Charcot and ankle fracture. It's very important to take these points in the history, examination, and X-ray of the patient. Usually, patient with Charcot comes with trivial or no trauma. And usually, the incidence of trauma is several weeks before the injury. Usually, the patient goes through the usual dilemma. He has a swelling. They think it is DVT. They went to vascular surgeon. Then they move to surgeon, general surgeons. It's a cellulitis. It may be gout, until someone makes X-ray for her and say, oh, you have a fracture and you have to go to orthopedic surgeon. This is the normal sequence you usually face in our clinics. Usually on examination, you will find the swelling and erythema is unilateral. Joint is markedly unstable. There is loss of pain. And the most important is proprioception, moving the big toe up and down, and you can see the proprioception of the patient. In the X-ray, it's important. It's very easy for you, and I tell this for my young colleagues. You have to look at this X-ray. You never see this in normal fractures. This is bizarre shape of trauma. You will have this indentation in the tibial plafond. You will have excess bone formation. You have